Am excited about today's webinar topic on managing symptoms of AML and finding emotional support. We have a great speaker for this webinar. Dr. Will Santivasi is a board-certified palliative care specialist at Duke. He's passionate about improving quality of life through symptom management and communication-centered care. He primarily works with hospitalized patients and emphasizes the importance of compassionate patient-centered support throughout the treatment journey. I am so excited to have him here with us and to present today. And I think with his specialty and his area of focus, you can see why we're excited to have him talk on this topic with us. So with that, I'm going to go ahead and turn all of our time over to him.
Thank you so much, Mary, and thanks everybody for joining. It's really great to meet all of you, and I'm looking forward to the conversation afterward. I did prepare some content, so let me get my screen shared. Oh, there we go. And everybody can see that okay?
Yes.
Great. So as Mary said, my name is Will. I am one of the palliative care specialists at Duke Health. I have the privilege of directing our consult services at Duke University Hospital, which is our large tertiary referral center in Durham. And I also teach at the School of Medicine. But more than anything, I love taking care of patients who have AML. It's a joy and a privilege to take care of patients regardless of their illness. And I'll talk a little bit about more of what makes palliative care special in that way. But in particular, patients with hematologic malignancies and AML, they're my favorite patients to take care of. One, because I think that you all are the most amazing people in the world, sometimes dealt the hardest set of hands, not just one hand, but multiple hands that anybody could be dealt. And two, because it's a privilege to be able to help in those moments of crisis and those moments of difficulty. We'll talk a lot about AML and what makes it special and difficult over the course of the next half hour. But I want you all to know we see you. And by way of a disclosure, while I don't treat leukemia, I treat patients who have leukemia. And we'll talk a little bit more about the distinction when we talk about what makes palliative care different than hematologic care. Over the next 30 minutes, my hope is that we cover really three topics. One is to define palliative care and better understand how palliative care specialists like me and my colleagues, either at Duke or across the country and across the world, take care of patients who have AML. To talk about some of the symptoms that we expect to happen when you're diagnosed with and initially treated with AML, and talk about the management strategies that your care team may use to help you to feel better while they try to fight your leukemia. And then lastly, to spend some time just recognizing how uniquely difficult it is to face this diagnosis and talk about what professional supports and also personal supports are available to you. So I don't think it's possible to give any talk as a palliative care specialist without defining what palliative care is. And I have a fancy definition. I have a definition that I think is more streamlined and makes more sense to me. And then I was also going to share quickly with you how I introduce myself to patients when I see them in the hospital. The Center to Advance Palliative Care, which is one of our large advocacy organizations as a workforce, has this long, fancy definition for palliative care, which I love because it touches on a lot of the things that makes it important and special in facing a serious illness. So palliative care is the specialized medical care for people who are facing a serious illness, where our team focuses on providing relief from symptoms and stress with a goal of improving quality of life, not only for the patient, but also his, her, or their family. The thing that's surprising to many people when they first hear about palliative care is that our focus is on what patients need. It is not about prognosis. It's not about how old you are. It's not about how advanced your disease is. If you are struggling with symptoms related to your disease or you need extra support, we want to be able to help you. And that's 2 paragraphs long. BJ Miller, who's a hospice medical director and palliative care specialist out in the Bay Area, who I really love his work, sums it up a lot better than that. He says, it's the interdisciplinary pursuit of quality of life for the treatment of suffering. And to me, the most important word in that is interdisciplinary, because I don't think that the lens that I'm given by my training as a physician allows me to understand the breadth of the lived experience of AML or any serious illness. So I get the absolute privilege of working with PAs, NPs, nurses, social workers, chaplains, and a bunch of other allied health staff so that we can combine our training and better understand every facet of somebody's experience and give them support in the right way and with the right professionals that are going to help them through their specific challenges and their specific journey. When it comes to AML, I think palliative care looks different because AML is different. I say this with the heavy caveat that there is no easy way to have cancer, but there is no more traumatic diagnosis in cancer or really for my money in serious illness than AML. When I talk to patients about their experience being diagnosed and starting treatment, it is a trauma. Many people, again, not that it is easy to have cancer, are given the emotional runway to hear the colonoscopy wasn't quite normal. We're waiting on this biopsy to come back. This scan doesn't look quite right. But the more I talk to people who are diagnosed with AML, they feel well except for one symptom, whether it's shortness of breath, they feel tired, their gums are bleeding, they're just bruising more. And the speed at which their life changes and a bomb goes off is instantaneous. That they go from being at their primary care doctor, just getting some blood work to make sure nothing is wrong, to presenting to the emergency room, to being either helicoptered or ambulanced to the or to the closest large hospital and starting chemotherapy within the next 24 hours. There's no opportunity for your mind to catch up. And as a result, patients with AML have higher rates of depression, anxiety, and post-traumatic stress than any other diagnosis in cancer. So there's a lot of unmet need where I think palliative care can be helpful. I think one of the coolest things that we've done in palliative care over the last 10 years is we've started to treat palliative care like chemotherapy when it comes to clinical trials. And what I mean by that is that we take patients and we randomize them in these trials to either receive the best leukemia care they possibly can, or in this study that I'm going to cite, the best leukemia care they possibly can have, and they meet a palliative care provider, either a doctor, NP, or PA at diagnosis. And during that first hospitalization, see that palliative care specialist or one of their colleagues 2 times a week for that hospitalization. And when we compare that to best care, those patients have better quality of life and they have less depression, anxiety, and post-traumatic stress, and their caregivers do as well. And the thing I found the most interesting is even though the study only covered palliative care during that first hospitalization when those patients got induction chemotherapy, that those benefits of quality of life and improved mental health actually are durable at 2 months and at 6 months. So there's something about that time and being able to give you support during that time, even if it doesn't go beyond that, that can help you to truly live better with this disease. So thank you for letting me get on my soapbox about what palliative care is and why it's important. But more to the task at hand, which is how do we help you feel better? What does that actually look like day to day? So let's talk a little bit about symptoms. I have some bad news and I have some good news, and I'll share the bad news first. Or I guess to make it sound nicer, I have some tough news and I have some better news. The tough news is being diagnosed with AML and being treated with AML means that your life is going to get hard. There are going to be many symptoms that come up. And for those of you who have lived through induction chemotherapy, I see some people nodding who have their video on. It's a really hard time for your body. It's a really hard time for your mind and your soul. But the better news is that we've done this enough as a workforce that your leukemia team, and if you have them, palliative care specialists, know roughly when these symptoms are going to come up for you and have a plan that's backed by data to help you to have those symptoms managed well while we treat your cancer. In fact, one of the things that we found is the most helpful is when I meet patients with AML or when my colleagues do, is to say, hey, here's a roadmap. You don't have to read it right now, but as you settle into this new normal, over the next couple of weeks, here's what you might expect. So week one really is about adapting to a new normal. And emotionally, that means a lot of complicated feelings. People feel overall really distressed. For very understandable reasons, they feel sad and overwhelmed, and they're just tired. And the tired comes from being kind of plucked out of your life and moved to a new area, from being stuck in the hospital, from having 100 visits, including in the middle of the night and having your sleep interrupted. There's lots of reasons that happens. Physically, as in that first week, you get diagnosed formally and you start treatment, people tend to get nauseated because of the chemotherapy. And then because of all of the things happening in their health, they can have bowel changes, whether it's constipation or diarrhea. By the second week, kind of once you're solidly past the initial phase of chemotherapy and into where we expect chemotherapy side effects to kick in, this is where things get physically very hard. Many patients, as a result of chemotherapy and also having their counts drop from chemotherapy, get severe mouth and throat pain. They get even more tired. They feel nauseated. They get diarrhea. And then in terms of their mind and their mental well-being, they get confused and they also have trouble sleeping. And again, a lot of that is our fault in the hospital for all the things that happen off of a normal schedule. In addition to that, because you're so severely immunocompromised at this point in your journey, you can have fever and chills that can be very, very unpleasant to experience. And then as you settle into the second half of the first month, things look even more different. That mouth and throat pain can continue. The fatigue gets very, very, very bad for a lot of different reasons. Around that time, a lot of patients report that their appetite drops off and that the things that they liked to eat, they don't like to eat anymore. And either things taste gross or the things that brought them joy just don't do it the same way anymore. And then there's this huge constellation of symptoms that happen around how they feel mentally. Their mood can change. The stress on their body of being in the hospital can lead to periods of confusion where you may not even remember the things that are happening day to day. For really understandable reasons, worry can get out of control. Let's face it, being stuck in a hospital for 4 weeks, you're going to get bored at some point. And that's a crazy thing to say when you're going through a difficult time in your life, but boredom is a totally normal emotional response to being stuck in the hospital for that long. And the trouble sleeping tends to persist, if not get worse. We don't have time in the next half hour to tackle all of this stuff, but I did want to touch on just a handful of these, which are fatigue, nausea, mouth and throat pain, and constipation and diarrhea. But more than anything, and if you take really, there are two things I want to emphasize. One of these is this: we know that these symptoms will happen for you. This is the disease, and it's the treatment for this disease. And so if this happens to you, and I'll even rephrase what I said, when this happens to you, nothing is going wrong. Many, many, many people are worried whenever they have a symptom that something is changing or that the doctors aren't being honest with them about what's happening to their health. If your leukemia team is worried, they will tell you. But one of the reasons why we offer this framework is to say, you're not the only person who's felt this way, and we expect that you're going to feel this way, and we can help you feel better. But let's talk a little bit about what that looks like in some more detail. The first thing we'll talk about is mouth or throat pain. You may hear your leukemia team refer to this by the fancier medical terms of mucositis or esophagitis, which is just irritation of the lining of your mouth and your throat. One of the things that's the most confusing and was confusing to me as I was starting my medical training is the things that you would treat pain with in any other circumstance are not safe when you have AML. So I would be really surprised if anybody who gets AML ever gets Tylenol or even an over-the-counter medicine like Motrin, because Tylenol suppresses fever. And one of the things that your doctors and your medical team are going to do is watch very carefully if you have a fever, because when you're immunocompromised, that could be a sign of infection. And medications like Motrin actually increase your risk of bleeding. And if you have a low platelet count, that's just not safe. And so for that reason, there are going to be a lot of prescription medicines that are used for pain. Many of those are coating or soothing medicines that are liquids that either sit in your mouth that are to be swished and spat out, or swished around in your mouth and swallowed, that can help you to handle eating and pills better. And a lot of patients are really surprised and frankly worried because they end up on opioid pain medicines. And those can either look like pills or liquids, or they can also look like IV if the mouth pain and the throat pain is really severe. So to give you some sense of what medicines we're talking about, I'm talking about things like morphine or Dilaudid or even fentanyl. And the reason for that is because they actually don't have the same side effects of Tylenol and Motrin, and are in fact some of the safest medicines that we can use in pain related to AML. And our job is to watch, safely use those medicines, and make sure that our patients maintain a safe relationship with them, and that it's only for a short period of time. In addition, sometimes the best thing we can do to support somebody when their throat is really raw from chemotherapy is to take their nutrition and automate it. And it's one of the few times in the hospital that will actually offer IV nutrition as a bridge. So as you get through your mucositis and your esophagitis, you don't have to worry about trying to keep up your nutrition if it's very painful for you. This is one of the most distressing symptoms that people face in their AML journey, and it's something we expect to get better. So when that heals, you will come off with medicine, and the vast majority of patients actually end up on no pain medication by the time they discharge from the hospital. Especially when we're talking about using things like morphine, Dilaudid, and fentanyl, many patients are worried, one, about the risks of those medicines, and two, what it says about their health if they're going to need those medicines forever. And that is almost never the case in AML care. The medicines that we use to treat AML, because it's such a tough disease, are really, really strong. So those chemotherapy medicines can cause very severe nausea and very bad vomiting. A lot of the time when you sign consents to do chemotherapy, with the chemotherapy recipe, they will also bundle in medicines to try to either prevent nausea or to make the nausea less severe. And many times it's not enough. The medicines that you may hear other people get because they went to the ER with a migraine, or somebody else in your family has a different type of cancer like Zofran or Compazine, they're great nausea medicines. And so oftentimes those are the ones that we turn to first. And there are some medicines that you may encounter in your journey that you've never heard of before. The one that you will see often used in AML care is a medicine called Zyprexa. The thing that's really interesting about Zyprexa is when it first came onto the market, it was actually labeled as an antipsychotic, and it was used in different ways and in different doses for patients who are facing either schizophrenia or another psychiatric illness. What we found is that at lower doses, it's a really effective nausea medicine. And on top of that, it can also help with sleep troubles and low appetite and anxiety. So it's one of the few times in palliative care where I can prescribe a single medicine for a couple of different symptoms, and that you can turn to the same tool to try to get relief from multiple things. Nausea and vomiting is also the symptom where we have the best evidence for efficacy of massage and acupressure if those are offered at your leukemia center. And many do offer those for inpatients. And again, once you are through the chemotherapy being in your body, this is something we expect to go away and that you don't necessarily have to live with forever. Along with some of the nausea and vomiting comes diarrhea. So diarrhea is a very, very, very common side effect that we know can happen when you get high intensity chemotherapy. One of the most frustrating things I think as a patient is the lag time between you telling your care team that you have diarrhea and them being able to safely do anything about it. Because patients with AML are so severely immunocompromised, your care team may need to rule out infections before they start to treat the diarrhea. And that can often result in a 1 to 2 day lag between you raising it as a concern and asking for help with it and getting medicines for this. Sometimes simple is best, and so we'll often start with over-the-counter medicines like Imodium, but there are also prescription medicines that help and work differently, like Lamodal or even octreotide, which is an injection that goes under your skin if diarrhea is very severe. Again, if this diarrhea is from chemotherapy, this is something we expect that will go away once it's washed out of your system and once you're through that cycle of treatment. It feels kind of crazy to talk about both diarrhea and constipation as things you can encounter, but it certainly is possible that both of those are part of the experience of living with AML. Most of the time, constipation in AML is related to you don't feel well and you're not as active as you usually are, number one. And number two, at least half of the medicines that I just talked about in previous slides are also constipating. So there's a very real chance that you could either alternate between diarrhea and constipation or have significant constipation even as you expect diarrhea. Over-the-counter medicines are something that we use in the hospital all of the time. If I can give you one piece of unsolicited advice, don't take a fiber supplement. Fiber is actually one of the things that makes constipation from medicines much, much worse. And it could have been a huge part of your life leading up to your AML diagnosis. Don't be surprised if somebody like me comes along in your life and says, hey, now is not the time for fiber. The other thing that's challenging about constipation and why we want to stay so focused on staying regular is anything that goes in the rectum. So suppositories and enemas are not safe when somebody has AML. If you have a low neutrophil count, the risk of introducing an infection from your GI tract is too high. And so we have to stay ahead of this and we have to be able to get good results from those first couple of things before it ever gets severe enough to consider something like that in order to keep you safe. The other symptom that is really, really severe and life-limiting is fatigue. And you're fatigued for good reason, right? The leukemia itself, your counts dropping, the intensity of treatment, the amount of times that unexpected things happen, or somebody just comes to check on you at 2 o'clock in the morning, and just the stress of all of this are very real reasons why you could feel tired. As an aside, I've finally seen the light several years into my career, and it seems silly to wake somebody up to ask how they're feeling. So during the daytime, I've really tried to practice what I preach. And if somebody is napping and that was a hard fought nap, I let them nap and come back another time. The best treatments for fatigue are not medicines. And that is kind of frustrating and disappointing because I wish there were a pill or a magic wand that we could wave and make you feel better. But a lot of the time, it's about adapting to your body's under a lot of stress, and this is a new normal for right now. So, how do you pace your day? How do you get the important things done first while you still have energy? How do we make sure that we make everything that you do with your body as efficient as possible so you can conserve energy for the other things that matter? And also, what can we do to help to ground you in the experience and help you feel in touch with your body and to also relax from some of the stress that you're experiencing? If you are facing severe fatigue with a couple of asterisks, the doctors and other people taking care of you may recommend a stimulant medicine like Ritalin if you know anybody who's living with ADHD. It can be a really effective medicine in order to stave off fatigue, and it has significant side effects. And there are lots of reasons why it may not be a safe and effective option for you as an individual. But it is something that we have fairly good evidence for, and given the opportunity, I will use it with my patients. It feels kind of arbitrary to differentiate between physical symptoms and emotional symptoms, but I think for the purposes of having 3 clean learning objectives, here's the dividing line. So let's talk a little bit more about the emotional challenges. And this is complicated. And it's honestly, even as a practitioner who does this for a living, sometimes confusing. But I want to normalize a couple of things. The people who are taking care of you when you face AML expect that this is going to be hard because it is impossibly difficult. And I would say because we know it's going to be hard, but that's not true. We've never lived it or met, or very, very few of us have lived with AML who also treat patients with AML. So we can only imagine what it's like. But many, many, many patients who have walked in your journey will have low mood, they'll have worry, they'll have fatigue, and they'll have difficulty with sleep, alongside many, many other things. Many of those will get better with time, and it's even possible that those will completely go away as well. They may also be part of your life from then on out. But the most important thing is that you are not alone. Many, 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 if not all of the things that you are feeling along this journey emotionally are normal. And there's so many layers that we can unpack that we just don't have the opportunity to do over this half hour. But there are really real reasons for your emotional life to be turned upside down by this experience. In terms of who can help, the people that have helped you best your whole life are going to be there for you. So your friends and family are actually your first line of mental health support. Lean on them. And oftentimes when you're going through a tough time in your life, they want to be helpful. And I've also counseled many, many, many patients over the years. If you don't give them really, really discreet advice about what to do for you, you're just going to end up with 100 casseroles. And that's too many casseroles. And there's nothing off limits, right? If you are struggling and you are in the hospital, hey, I need you to walk my dog. I need you to mail this check for me. I need you to weed my garden. People respond well to direction. They are there to help you and support you through this. The other people who can support you are the people taking care of your leukemia. Underneath every leukemia specialist provider is somebody who trained in a field like internal medicine and has a really broad base of medical knowledge outside of the disease that can also help you to better understand what you're going through emotionally and when that may rise to the point of being a medical problem that needs intervention. Although AML care often pulls you out of your circle if you don't live very close to a large academic hospital, it does come with the benefits of having large cancer centers attached to them. And oftentimes those cancer centers have structured support professionals and support programs that can be incredibly helpful. And that can look like a lot of different things, including psychiatrists and psychologists, social workers, various forms of therapists, including people in allied health professions. And there's a delivery. Hold on one second. Minnie, that's fine. Minnie, give me 2 seconds, y'all. Sorry. Apologies for that. The best laid plans of mice and men. We were talking about professional sports within the cancer center. So there are many, many forms of therapy in cancer support care, and that can include physical and occupational therapy, recreational therapy, talk therapy, medical family therapy, lots and lots and lots of helping professionals that are able to help you. The palliative care team, so medical providers like me, as well as specialist social workers and chaplains within palliative care, have mental health training to help to support you. And especially being connected with a group like HealthTree, other patients and their friends and family. No one is going to know this journey better than people who are going through it with you or have been through it before. So they're really the best people to talk to. At the same time, having support and talking through things may not actually be enough to feel well. So there are also times where we have to deploy medicines to help people with their emotional challenges. And so I want to talk about when medicines can help and also which medicines can help. One of the hard things about AML is this is a really tough time and it is very understandable to have emotional challenges. And we also know that many people who face this diagnosis will go on to develop either a mood disorder like depression or an anxiety disorder like GAD. And diagnosis can be very, very tricky. If you have lived with a mental health issue or if you know somebody with a mental health issue, many of the screening questionnaires that we ask patients, for example, in their primary care clinic, include questions about changes to appetite, changes to sleep, changes in energy level. Well, guess what? You're living with AML. You're going to have problems with those every day. And if we used those same tools, it would look like every single person had major depressive disorder, and that's not true. So as we've studied this a little bit more carefully, there are two symptoms to watch out for that may suggest that you're facing a mood disorder or an anxiety disorder beyond what's expected for the AML journey. If your low mood also includes inability to enjoy the things that you love. So if you are a crocheter and that is really what brings you joy, and somewhere along the way you go, I just don't want to do this anymore. I get nothing out of this the way I used to. If you're somebody who loves to spend time with your grandkids and all of a sudden that's just not something you want to spend your energy doing, that may be a sign that something more severe is happening. I had one patient who summed it up better than I ever could. And she said, it feels like all the color has gone out of the world. And that's a really, really awful thing to have to live with, and is something that we can help with. The second is if your low mood rises to the level where you're having feelings of guilt or worthlessness beyond just having a low mood. Those feelings also may suggest that you're facing something like a depressive disorder in addition to coping with AML. In addition, if the severity of your low mood or your worry impair your ability to function, and you're not able to live your life the way you want to because of the impact that these things have on their life, that may be a time where we turn to more intensive help, like medicines, or refer to other mental health professionals. So let's talk about which medicines can help. Worry is part of living with AML. Your body and your mind can only face so many unexpected things before your body starts to try to automate the worrying process. And so anytime you feel something new, anytime something doesn't go exactly as you've expected it to, it's very natural to feel worry. And if your mind can't disconnect from that worry, that may be the time where medicine might be helpful. So although it's a higher risk medicine, we do use a fair bit of benzodiazepines like Ativan or Valium in the hospital. And then, as we had talked about before, Zyprexa at very low doses can also help, in addition to nausea, with things like worry and with sleep. And they don't last for very long. And they're higher risk medicines that don't have as much evidence behind them. So there are also longer term medicines. So the class of medicines we use the most often is called SSRIs. So you may hear people talk about those, or medicines that are related to those. And those can be effective both in helping low mood and worry, but the biggest problem is that they take a couple weeks to work. And we know that for a fact. So in making the choice to start a medicine, it may be 4, 6, 8 weeks before you really get around to feeling better. And that improvement may be slow, steady progress, where it's not that there's a day where you go, wow, I feel a lot better. But you look back and go, wow, 2 weeks ago, I really felt different than I do now. But every day, the change was really small. The other reason why it's really important to talk about mental health as it interfaces with physical health is it all comes together. And I am the product of many generations of very wise Philadelphians. And so something I've gotten to telling patients is if you feel better, you feel better, which is a not very medically savvy way of saying if you have control of your physical symptoms, it's going to be much easier to have a better time emotionally. And the better you feel emotionally, the easier it is to cope when you have symptoms. So there's no way really to pull these things apart from one another. If you feel better, you feel better. And if you feel worse, you feel worse. So that was really what I wanted to talk about. Thank you all so much for letting me talk to you for a couple of minutes here. I am going to turn off my slides, and I would love to take any questions. I think a couple of things popped up in the chat that we probably can start with.
Right, I will go ahead and share my screen as we get going with the Q&A. So if you have questions and comments, you can share those comments in the chat, or you can ask them verbally. So you could raise your hand and then we can go through those questions um, as they come in.
And it's okay, Mary, too, if I set the guardrails of it doesn't necessarily have to be about just what we talked about. If you have any
Yeah,
questions
of
related
course.
to palliative care and AML, I'm happy to answer them.
All right, Brian, do you want to start us off?
Sure, I always go first. Uh, Thanks for having Will on. I guess I always just assumed palliative care was synonymous with end of life, but I guess that's kind of where we're all at anyway. Um, but that's interesting to hear. Question number one is, you kind of were mentioning it, but do you have any, peer support people attached to your group of providers? And the reason I say that, I was in the fire department for a very long time. And it wasn't until we developed peer support that a lot of our, mental wellness issues kind of got dealt with. So you kind of talked about that, but I'm wondering if, like, I've thought about this when the doctors came in several times, both during my transplant and my induction. I would have loved to have had them have a peer that I could have talked to who had gone through AML. Like that would have been a big deal for me. So I'm curious about that.
That
Yes.
question,
Oh, go
okay.
ahead, Mary.
No, I was just clarifying if that question was for HealthTree or if that question was for,
Uh, I know that HealthTree has coaches and I've signed up for
okay.
that part of it. I'm curious about like actually at the palliative level.
So the short answer is yes, and it depends on which center you're at. And most of the time, peer supports and peer coaching is actually through your leukemia team. Every now and again in the palliative care world, we'll have a patient or family say, I really want to be in touch with people who are going through what I went through. And usually the way we structure that is we have them talk through, if let's say they had colon cancer, we have them actually go through the colon cancer clinic because they can actually meet a lot more patients earlier. The big challenge, Brian, as you I think so eloquently put, is many patients and families are worried that palliative care is end of life care, and that often delays our ability to help. And the reason why people think that is because until probably 15 years ago, that was the case. Um, there are many generations of docs and other healthcare professionals who have come and gone who didn't have the opportunity to specialize in the field I have. You've only been able to be a board certified palliative care doctor for about 20 years. So we're kind of new on the scene compared to a lot of the other fields. And back in the day, we really had a different mindset, especially in AML care, of we either treat the leukemia or we focus on symptoms. And we usually waited for things to get to a really late, difficult stage before we started to manage symptoms. And eventually, over time, we went, that's not the right way to take care of people. So even just in my short career, because I came out of medical school in 15, there's been a lot of positive movement toward getting palliative care involved as early as possible and helping people to understand, although we can definitely help with things like end of life care and decision making around when is the right time for hospice, what does this mean for me? We have a lot of value to add way before that too. So great set of questions there. Did you have another one?
No, thanks. Oh, I got 5,000, but I'll let other people go.
Did you have a question you wanted to ask? One?
Yeah, hi. Um, so part of it's not really a question, but more of a statement. But is palliative care going to become standard of care for AML patients at some point? Because I know that that was something not really available. Nobody came in and said, okay, this is what's going to happen in week one. You know, these are the systems. You know what I mean? There was nobody who was focused on that. Will this at some point become standard of care?
I desperately hope so. And the more people we can have allied with that vision, I think, Alan, the easier it'll be. The big challenge that we're facing right now is there are many more patients who could benefit from a palliative care specialist than there are palliative care specialists in the world. And trying to find the right mix of how do we meet people at the right time so that we can actually help them. Because there are also many people that if we paint with too broad of a brush, it's a meet and greet and we don't talk about anything. If you're one of the people who goes through and they don't really have intense symptoms and they're doing okay and their supports are keeping them going and they're really not suffering much, that's a visit that could have been for somebody else who has more severe symptoms in that moment. And so that's really the second generation of studies that we're trying to run in AML is to better understand how do we meet the right patients at the right time and how do we build a relationship that's trusting and profound and important and also is the best use of resources so that we can meet as many patients as possible. But I would love to see a world in which it's standard of care because I really do think that we can help in a big way.
Margaret, you're muted. Yes.
Sorry. I've just been having a really hard time with all this. I finally got into palliative care a few months ago. I've been going through chemo. I haven't never had to stay in the hospital for chemo. Mine kind of came on slowly with high risk MDS, and I've done a lot of research myself. I have a lot of problems, like I cannot talk to family and friends. Um, I mean, I lost my husband 10 years ago to suicide, and I had two other cancers, and I beat both of them. And now I've got this one. And anytime I try to talk to him about how I'm feeling, oh, well, we could all just die tomorrow. So, you don't have us need. And to me, that is so setting and it's constant. Well, why aren't you doing this? Why aren't you doing that? There's a lot of reasons I'm not doing things,
Yeah.
and I have a hard time dealing with these people. I had a lot of trauma in the past 10 years. And I chose not to go ahead with the uh, transplant. I have so many comorbidities, or yeah. I mean, I have something very rare called malignant hypothermia, factor two, blood clotting disorder. So I'm on anticoags. But the big thing I have problem with is fatigue, but the muscle pain. My muscles are constantly in pain. And is this usual for other people? I mean, because there's times I can't pick up anything with my arms. I'm going to PT. I've been going to PT for about a year now, trying to get some strength. And I am. I actually feel better than I did a year ago. But still, I'm just really stressing out over a lot of things.
You're carrying a lot, Margaret.
Yeah, I am. And
And and I hear
I live,
you. I think, oh, go ahead. I'm sorry.
yeah. Well, I live alone, on 9 acres of woods, isolated. And I have two cats. Oh, you shouldn't get cats, blah, blah, blah. Well, you know what? That's the best thing I ever did was get those cats because they don't judge me. They make me work. I don't know what to say or think, but I'm so happy to have this available today.
Yeah, what HealthTree does is a gift. Having this technology and this way to connect with people, especially when you're facing a rare disease like you are, it makes the world flatter in the best and most important way.
Yeah,
Because you're one in a million in the United States, that means there are 350 people just like you. Um,
great.
the other thing is what you are facing, or what it sounds like you are facing when you share the way that some people show up to help you. You are also not alone. There are many, many people who, when they go to friends and family who have never had somebody sick like this before, their heart's in the right place. They mean the best by it, but the things that they're sharing are not helpful. And I could write you a book, and actually, there are a couple of books that have been written of just here are things not to say to somebody who's going through a serious illness, like
Yep.
God never gives you more than you can handle, like everything
Great.
happens for a reason, like, well, why
Yeah.
don't you just try XYZ? Why don't you just try harder? It's just more complicated than that, and life is more
Yeah.
complicated than that.
And why aren't you keeping your house clean? Well, I do bits and pieces when I can, but I can't a lot of the time,
The best you
and
can do,
that's,
the best you can do is the best you can do.
yep,
And
yep,
I think leaning on personal and professional support to the best of your ability, and learning where some of those sharper edges are, and when you go, oh, actually, maybe you're not the right person for me to turn to in this moment.
yeah.
I think that's the right play. And this is easier said than done. So when you figure it out, tell me. But self
Well,
compassion is
well,
just
those
to be
cats, wherever
gentle,
they
to be
are. Yeah,
gentle with yourself, and make sure that the voice in your heart also recognizes and owns everything you're going through,
yeah,
and give yourself grace, even if the rest of the
yeah.
world chooses not to.
Well, I was a special ed teacher in a poor area in a middle school. So, I mean, I'm used to dealing with traumas, and I was the kids' go-to person. They wouldn't even go to the guidance counselor. They wanted me. Um, and I missed teaching. I had to give it up because I was too tired to teach. Um, it's just, I do have a little neighbor who lives a half mile down the road. She comes and visits me, and we do art together. That's
That's
my biggest joy
That's
is
amazing.
well, I go to Dartmouth Health and they do have a complimentary care. And the thing I like the best is the art and the qigong.
cool.
So I do those two things.
I think being able to ground yourself in the experience of the creative arts, in addition to what you can express of yourself, but just to feel your hand on the brush, your hand on the pencil, and to be mindful in that moment is transformative.
Yeah, there's a pencil and there's
There they are.
yeah, the brushes are here too. I have a whole bookcase full of things, and I wish I could share it with more people. But again, those are limited times. We
Yes.
have a theme and stuff, but I need more things like that. And the writing is not me. I'm not a writer.
Neither am
Uh,
I.
and they have some kind of music thing you can go on and listen to aging group or something. And I'm there. I don't sing. I was told in second grade, keep your mouth shut for a reason. Anyways, thank you for listening. I
Oh,
just
thank you for
feel
sharing.
very alone. Yeah.
You may feel alone, and you are not alone.
Yeah.
And it's
I,
easy for me to say that from inside the screen, inside the box on the
yeah.
screen. But
I would love to, there is a support group for, but we only talk about cancer. I would just love to have some place like some little chat thing I could just go to and hey, what's new this week, But yeah, the most friendly people I see are the Meals on Wheels people. Because I
Thank you
need to
so
get
much for
cooking.
sharing. And thank
Yes.
you for being honest about your experience because,
yeah,
like was just said, it's an extremely hard place to be, and the things you're going through are really tough. And it's helpful, I think, for other people to hear that someone is experiencing something similar to them. And
Yeah.
so, like we were just saying, it's a unique experience for you, but other people also have similar ones. So I'm glad that you felt comfortable enough to share, and I would love to connect with you afterwards. We have some resources that might help. So I
Oh,
will follow up. I'll send you an email with um, some information, even just about our coaching program, which is a one-on-one mentorship program. Some of the people on this call are some of our coaches, and they're really
oh,
incredible. Yeah,
yeah,
there's
I would love
Alan
that.
and Sue. Both of them are coaches.
Oh,
So,
good.
um, and it can be to talk about your disease. It can be to talk about whatever you want. It's just to provide some support and some community. So I'll
Thank
send you some information after that because I want to be able
thank
to
you.
help where we can.
thanks, Mary.
Thank you so much.
And Sue,
I just wanted to thank you for this conversation. When my husband was in the hospital, they sent in palliative care, but probably not till the fifth time he went into the hospital. And they didn't explain palliative care. So he looked at me and he said, "Do they think I'm dying?" And I felt so bad because that's what I thought of palliative care too. And I knew nothing. I didn't understand it. And they didn't really explain why they were there. But I wished that we had dealt with them more because the doctor that we dealt with, she did tell him because he wasn't sleeping, she said, "Well, use some gummies." She said, "Your doctors won't approve of that, but I'm here to tell you if you don't sleep, you don't sleep." And that's what he did. And he was actually sleeping and it was great. And the palliative care doctor was awesome. But again, they don't come in right at the beginning, or they didn't at the time come in at the beginning. And I think that would be so important, but also to explain who you are and what you do, because he thought he was dying and he thought that's what they came in for.
Yeah, and I think so. You are certainly not the only family student that's had that experience. And one of the things I'm trying to do as we educate kind of the next generations of healthcare professionals, we're especially like anything else, like cardiology, like nephrology, and the way we get involved matters, and how you frame our involvement to patients and families matter. And so I think it can be so much more healing and allow us to get off on the right foot if your leukemia team says, "Hey, I'm asking the palliative care team to come and see you. What I really want them to help you with is this." I think if somebody had just taken that next step of saying, "This is
Yeah.
where we think they can help you," it would have saved, it sounds like your husband and you, a lot of pain and worry between hearing they were coming and then walking in the door.
Yes, and it would have helped to explain what they did, or why they were coming in, because we didn't understand it. And you're sitting there going, "Oh
Yes.
my God, you're going to die soon." And it was, and he lived a year and a half after that. So, that was great.
I'm glad that they were able to help you. And I also wish that you could have met them sooner and with a cleaner handing of the baton to the next team.
Yes.
But yeah, I
Thank
think one of the best skills an early palliative care specialist can learn is what's your elevator pitch to a patient? How do you
you.
explain what you
Right.
do? Because it's kind of weird, right? I mean, when I go in, I say I don't have one disease I specialize in. There's nobody else in a large hospital that says something like that.
Right.
But what I do focus on is support, right? And that is really customized and obviously draws on my medical training, but it's really more about you as a whole person.
I'm glad to see it's changing.
Me too.
Thank you.
and Sue, we were talking before the call started, and I was sharing that I had been talking to an AML coach about this whole topic and that we're going to be developing some resources on palliative care. So it's nice to kind of close the circle and have everyone talk here. Um, we're going to be working on developing some resources to help explain palliative care and the importance of palliative care throughout AML. So I'm excited to be able to work with a whole group of people to make sure that we get these resources out there because it is such an important topic.
It is. And it really would have benefited more had this doctor come at the beginning and then they had explained what she could do for him, because we didn't understand. And the diagnosis itself is scary enough, let alone having a doctor come in that you think, okay, I'm dying now, so I guess it's over with.
And I think there's so much of your worry, understandably, as a patient or somebody who loves a patient, is what are the doctors not telling me?
Yeah.
What does this, trying to read meaning behind decisions is really, really hard. And that's why it's important and hard and tough, because you're kind of thrown into a situation. But how do you build a relationship where you really trust the people that are taking care of you?
And they don't always tell you everything.
Yes.
They don't explain it. So when my husband had AML, I didn't know about HealthTree. And so I was looking on the internet to find out what the hell they were talking about, because
Yeah.
the words I didn't understand. I was trying to relay it back to the family because it was during COVID. And I'm looking up stuff and hoping to God that it's right off of Google. But,
Yeah.
I'm so
And
grateful for HealthTree.
it's a good group for sure. Eileen raised another really important point, and I wanted
Yeah.
to include something about this exact topic. Not exactly hair loss, but Eileen was just sharing the journey of losing her hair and um, just how much stress that causes, the changes that you feel in your body, and even just the ability, like just even the experience of not being able to control or lean on your own physical self to do the things it used to do, whether that's have a head of hair, be able to walk to the bathroom without help. Depending on how you got to your AML journey, it may be the first time in your life that your body has not been able to keep up with the stress it's under in this way. And it's so upsetting. And that's to say nothing of your sense of self, right? I mean, who you are, your driver's license, every picture of you is of your face, and there's a lot of hair on that head. It's these things are individual losses to be grieved alongside everything else. And I think it's really important to label that outright.
I agree. Thank you. Yeah, I mean, I expected it. They had told me that would happen. I don't know if I expected it to just all fall out and kind of clean it up and put it away, but every day, when I fall asleep, I'd wake up, there was just hair everywhere. And I couldn't keep up with it. I had a lot of hair. I did have a lot of hair.
And no matter how much somebody prepares you, it's upsetting.
Yeah.
Right. It's the it's now happening to me is very different than there's the risk or what if or
Right.
I worry. When
Yeah.
it's real life, it's real. And even if you are 100% mentally prepared in terms of your higher brain that thinks thoughts, none of us can control the feelings that we feel. It's gonna come with feelings, and those are all completely normal and understandable.
Thank you for sharing that, Eileen.
Yeah.
Alan?
Yeah, I just want to follow up on the losing hair comment. This might be a little weird, but when I was, when I lost my hair in the hospital, at that time I felt like I had no control over my life. Everything was dictated by, my medicine schedule and my doctor visits, whatever, whoever was coming in the room.
Yes.
And I felt was so powerful that I had control to decide that I wanted my nurse to shave my head at that point. It was like really a powerful
Mm.
experience for me. It might be a little strange, but that's how I felt at the
I
time.
don't think that's strange at all. So two things. One, I think you felt that way because that was reality. Your whole life was controlled for you, either by your disease or by the things that the doctors were doing to try to keep you safe from it. But that is something I am often giving recommendations to other doctors about, is so much of the experience of any life-threatening illness, let alone AML, is a fundamental loss of control and agency over your own life. So one of the ways that we as a care team can help you is to try to protect some spaces where you can have a say and to give you a choice where there is choice. There are some things where, look, they're just medically, it's not safe to do something else. We have to do this. But there are lots of ways in which there may be three different ways to this outcome. Which way do you think, as the person who lives your life and knows you best, is the right one for you? To give you a little bit of control where it's possible really can help you keep your head on straight in a way that nothing else can. So good for you for finding that moment of saying, this is one way where I can have a say in my life and taking advantage of it.
I want to thank everyone for all of your comments and your questions. I think this has been such a great experience. I have felt like I've learned a lot throughout the presentation, also through listening to individuals' experiences and seeing people being able to help each other on the call. Brian?
I'm wondering if we can call you Will, I suppose.
Yes,
Is there
absolutely.
a way to create a contact with you at Duke? Or do you have a web page or something like that to be able to start from there so we can start looking at other places that do palliative care to understand more about what's out there? Like,
Absolutely. And so I would also love to loop in Mary and Mary Lou, because that was the conversation, like Mary said, we were having right before this launched, is if there's anything I can do as somebody who's in this world to make it less mysterious and less frightening, I'm game. And there are lots of people who do what I do who feel the same way. And I think it would be really nice for us, even within HealthTree, let alone doing something else, to say who are the people who are out there, so that there is a face, even if that person's not in the hospital or the clinic that day. When somebody who's connected with HealthTree is in the hospital, who are the people we know they can turn to? There's a good news and bad news piece to this. We're at a point in the history of medicine where there are lots and lots of hospitals, especially the places where people get leukemia care, where in-hospital palliative care teams have kind of become the norm. When you get out into the community, smaller community-based cancer centers, ones that don't have teaching hospitals attached to them, in the clinic, really it's only about 50-50. So even there's a lot of clustering of palliative care that happens at the big centers. And out into the community, that's really our next move, is how do we make palliative care more accessible? And Margaret's story of using telemedicine, that's been a big piece of this since 2020, is all of a sudden our clinic went from being 100% in person, or 95% in person, to 80% virtual. So how do we extend this expertise and these people to places where they otherwise wouldn't be?
Yeah, I will work together and we will make sure that we have something that we can send you, um, even if it's just a contact first in the follow-up email from this event. So we'll make sure that we get something out, because this is obviously something that is important and matters a lot to AML patients. So we'll make sure we make some connections so that we can get this type of care available to everyone. And I also want to say we can make it available. I have some time. So after we finish the webinar, we can stop the recording, and anyone who wants to stay on and talk to other people on the call or ask questions, we'll make that available. So once this is over, I'll stop the recording and then I'll stay on for anyone who wants to stay on afterwards.
Yep, and I'll stick around for a little bit too. Thank you
Perfect.
all so very much. And because I didn't say it out loud, thank you for also letting my dog crash the conversation for a minute. This is her thing. I've only given a national or international talk a couple of times since we've had her, and she somehow makes her presence known, and no amount of preparation can ever stop it.
Yeah, that's how you know these things are live, right? Life happens. As you leave the call today, so whenever that is, and you click out, Zoom is going to prompt you to take a 2-minute survey. Especially after a topic like this, I would love to hear your thoughts and your opinions, potential other topics you want to get into, so that we can make sure that we're tailoring the educational content that we're putting out to the needs of our community. So please take 2 minutes to fill that out so that we can have your thoughts on what we should be doing next. And then I have a couple of events to talk about. So I mentioned this in our last webinar, but we're going to be doing a virtual regional education series throughout August and September. And we're working on finalizing those dates, but the registration pages should be up soon. So these regional webinars are two main goals that I have for them. First is to let you hear from an expert that's in your region about practical information that you need after an AML diagnosis, and then to help manage your disease throughout your whole treatment experience. And then the second goal, and the reason we're doing it regionally, is to bring you to direct links to resources that are in your area. So things like other nonprofits with support services close by, companies with special support or resources for blood cancer patients. I'm going to include now potential palliative care centers, things like that. Because companies that support blood cancer patients, support groups, anything like that that we think can add to the support that you need and deserve during this time. And then at the end of the presentation, after the resource sharing, we'll also leave the time open for you to meet and connect with the presenters and the other patients and caregivers that are in your region. I'm really, really excited about these events. You'll be receiving an email soon that has all of the links that you can register for your region's event. If you have any thoughts on topics or specific resources that you would want included in this event, my email's on the last slide. So please send me an email and let me know so that I can make sure to plan that, especially for your region. And then with today's topic, I also wanted to highlight some past webinars that are on topics that are similar or related that might be helpful for people who attended this topic. Many aspects of an AML diagnosis can feel heavy and feel lonely, like we've heard today. And we have some great resources that you can reference if you're looking for additional support after this call. So the first one I want to mention is a recent webinar we did on coping strategies for anxiety and uncertainty around a blood cancer diagnosis. It was a really great webinar. We got a lot of really great feedback from patients feeling like it really did help them address the needs that they have right now. And then I wanted to mention a webinar that we did that was specifically focused on caregivers and providing strategies and help to address their experience with AML. And then finally, we did a really great webinar with a panel of a caregiver, an AML patient, and an oncology social worker that talks about navigating grief and end of life planning. I think it was really well done and provides a lot of good support with empathy and with understanding. So all of those links to those webinars are going to be included in the follow-up email as well. So this email is going to be jam-packed with lots for you. So if any of those topics or resources sound like they would be beneficial to you, I hope that you look at them and check them out. And then something to mention, this is a new series that we're hosting and they're in-person events. So if you live near any of these cities or are interested in attending any of these events, they're free. They're going to have patient panels of patients local to the area. So some of these cities, like the later ones, we're still recruiting for the panels. So if you live in this area and you'd be interested in participating, we would love to have you on. And then we'll also have an academic center physician and a community physician to talk about what the coordination of care looks like, especially for patients who are not able to be regularly seen at an academic center. So it's a really cool conversation. We've hosted, I believe, 4 so far, and they have all been incredible. I'm personally going to be at the events in, let's see, in Austin, Texas, and in Grand Rapids. So if you live near any of those, I'd love to meet you. All of the other events, someone from my team who is a manager over other diseases will be there in person to meet. And we usually have like 17 members. So lots of HealthTree people. It's a great opportunity for patients to be able to hear from people local to them. And we also, it's across blood cancer. So they're larger events with more people. And we also have like a resources fair outside of the event. So local groups can show up to provide resources in person. So they're really cool events. If you live near any of them, I would highly suggest going. Like I said, they're free. It includes some meals and some resources. So really cool events that are available to our communities. Again, we're really grateful for the support of our AML sponsor, Cura Oncology, who makes us doing events like this possible. And then before we finish, I just wanted to say thank you for being a part of our community, for coming, for sharing your thoughts, for asking questions. Your support means a lot, and we're really grateful to have you here and to be able to provide resources that are beneficial to you. This is my email on the screen, so please don't hesitate to reach out if you have any questions about anything, programming, things that you want to see. I also set aside time every week, specifically on Mondays and Wednesdays, but it's available any day to meet with members of our AML community so that I can get to know you, to hear your story, to hear about topics you want us to cover. It's my favorite part of my job, so please don't hesitate to reach out. I love getting to know people better so that we can make sure that I'm tailoring the education to the needs of the people who are joining our education. So with that, I hope to see you at another webinar soon. And like I mentioned, I'm going to go ahead and stop the recording and stop sharing my screen. And then we can, anyone who wants to stay on and talk to anybody else or has any questions, we can go ahead and go through those. And Mary Lou just sent me, it looks like we had a question that came through on YouTube that I will go ahead and ask. and they asked how effective is a stem cell transplant. They're very worried. Their doctor said it's 75% chance of surviving the process. I'm not sure if that's a great question for here, but we can make sure and get that answered.
I can tell you what I know about stem cell transplants. So I think probably the best response is the one that's the most frustrating, which is the process of being evaluated for and choosing to move forward with stem cell transplant is so personalized and so customized to you as a person, what other medical problems you're facing. So I would, to that question, my first response would be make sure you have a really good conversation with your leukemia doc and whoever you're going to trust with your transplant care. And the trade-offs may be super complicated. Oftentimes when we're talking about transplants in AML, we're talking about allo transplants, so transplanting somebody else's bone marrow into your body. Those come with more potent chemo regimens that are stronger and have more side effects, the risk of graft versus host disease, and overall a rockier course medically, and the complicated balance of what I could benefit in terms of helping me to either live past or through my leukemia versus what I'll have to go through in order to accomplish it is very complicated. And that's one of the roles of a palliative care team. If you are working with a transplant center that has embedded either hematology palliative care or a palliative care clinic or inpatient practice otherwise, is another person with medical training to talk through this with, to kind of hear information from the people treating your cancer and are considering your transplant, and also to have somebody who's trained like I am to hear a little bit more about your life and figure out where this fits in. And the reason I think it feels hard and scary is because it is hard and scary.
Yeah.
The stakes can't be higher than the things that we're talking about.
Yeah. Thank you for answering that. Now that we've